Good morning, everyone. It's so nice to see all of you in person. I'm so happy to have Dr. Diana Montoya-Williams here in recognition of Hispanic Heritage Month. She'll be presenting today on understanding immigration as a social determinant of perinatal health. Just a brief bio for this wonderful, fabulous neonatologist, my friend. Dr. Diana Montoya-Williams is an attending neonatologist in the Division of Neonatology at Children's Hospital of Philadelphia and the Hospital for the University of Pennsylvania, and an assistant professor of pediatrics at the University of Pennsylvania's Perelman School of Medicine. She graduated from Harvard College, attended medical school at Columbia, and completed her pediatrics and neonatology training in Florida. She's an NIH-funded health services researcher who studies inequities in maternal and infant health outcomes that occur by race, ethnicity, nativity, and preferred language, including a focus on immigration policies as determinants of perinatal health. So we will have time for questions at the end of her presentation. And for those of you who have joined us online, please use the Q&A chat in Zoom. And thank you for joining us. So please join me in welcoming Dr. Montoya-Williams as our speaker today.
Good morning, everyone. It's such an honor. It's such an honor to be here. I love this campus. I've always loved this university. So it's so great to be able to come in person, especially during this month. So today we are going to talk about what you said, what I put on the slide. I do have some disclosures. I do some health equity consultant work for 2 different research groups. And then in addition, you'll hear me talk about maternal or women sometimes, depending on the primary literature that I'm citing. But this presentation and all of the data and concepts are inclusive of all pregnant and birthing people, irrespective of gender. And then also, you might hear me say Hispanic sometimes, or Latina, which is the term that I'm more frequently trying to use now. And we can have an offline conversation, or you can ask me later about the fact that those are not interchangeable terms, but I am using them a little bit interchangeably in this presentation, just for ease. So these were the learning objectives, but I'm going to dive right into the actual content. And to really be able to understand those contents, this is the journey we're going to take. I'm going to start with a little bit about me, and you'll see why. We're going to talk about foundational concepts that I like to talk about at every talk, because I think it's really important that we're all speaking a common, same language and have a shared understanding about certain concepts to be able to understand how those concepts then translate into policy and health. And then you'll hear a little bit about my personal search to contribute and how some of my work has evolved as we try to improve immigrant health outcomes, and particularly Latina immigrant health outcomes through policy work. So a little bit about me. I'm a bilingual, bicultural, first-generation Colombian immigrant Latina. And I really love to start with that because it is so critical to not just who I am, but the work that I do. I'm a neonatologist, as you heard. I'm a wife and a mother, and as a maternal infant health researcher, you can absolutely bet that that impacts the work that I do, both in the ICU and in my research. And I aspire to every day make sure that I'm being a health equity scientist so that we are approaching health equity with the same rigor and methodology that science is held to, but for the purpose of health equity. And I always start with this because who I am deeply impacts what I do. And I think it's really critical that we understand the strength that can come from our identities and how we can really learn to harness that strength and power, both in the clinical work that we do, but also in the academic scholarship that we do, versus try to leave it at the door or use any other phrases that are commonly used. I have found power in my identity in the research that I do and how I translate it into advocacy and policy. And I also have to understand my implicit biases that come from those identities, but all of that can be so powerful. So I find it very important to ground myself and my presentations in that. And I encourage you to ground your work in your own identity. So common language. I'm going to show you data that really drives me because it makes me angry. So racial disparities in infant mortality are what drive my work, my everyday, both in the ICU and in my academic work. And they are preventable, which makes them inequitable and unacceptable. So this is data from National Vital Statistics, so it's the entire country. And what you're seeing are bar graphs that just are different heights, and they shouldn't be. That's basically what you should take from this is these are different racial ethnic subgroups with bar graphs that should be all about the same if we are providing healthcare and people are experiencing health the same in this country, but that's not the case. But this is racial ethnic. subgroups. And my career and what I'm really passionate about is diving a little bit deeper into these types of graphs and understanding more nuance than what some of these graphs show. So in particular, I'm very interested in adding nativity or where someone is born to these types of graphs. We know that disparities in infant mortality are rooted in preterm birth disparities. So preterm birth absolutely drives infant mortality in this country. And so understanding preterm birth and preterm birth racial disparities is how we have a better understanding of racial disparities in infant mortality. So I'm going to show you some of my epidemiologic work that I've done with some of my mentees to be able to ground then the discussion we have about concepts and what we do about them. So this was a study that I did with a student of mine, Alejandra, who I met through one of those summer research programs that are specifically focused on underrepresented minoritized people. And she stayed with me through that summer and then beyond, and then became a data analyst. And now she's a first-year medical student at Yale. And so I really want to focus on that because there's so much power that those of us in a room like this can do to combat disparities just based on who we decide to take on during our summers for research. So it's really critical work that we can all do. But this is the study that she did. We used national data to really try to recreate those graphs that I showed you at first, but adding that level of nativity where someone is born. And so what you're seeing here, very similar graphs. This is preterm birth, not mortality, but we've added on where someone is born based on US versus foreign born. So the darker color is a US born racial ethnic group, and the lighter color is the foreign born subgroup of that racial ethnic category. So you can see US born Hispanic white in yellow, the dark yellow, and foreign born Hispanic white in the light yellow. And the other thing you'll notice that we did here that's different from the previous graph is that we added race to the ethnicity subgroup. So Hispanics are separated in terms of Hispanic white and Hispanic black. And what you'll see is that that's important to do because those patterns are different. The patterns are different when you take into account race within an ethnicity, and the patterns are different when you take in nativity within a racial ethnic group. So there's a little bit more granularity that we wouldn't see and we wouldn't capture when we don't take into account nativity and we don't take into account race. What this makes you think is, well, then there might be something different about the individual then, and we have to just take into account all of those different demographics to really understand the individual and their risk factor. But I've also done some work with other mentees to really start to show that racial disparities have a lot to do with where you live and where you're giving birth. So this was a study that I did with another mentee who is a first-year medical student at Emory, similar summer programs. And here we looked at the intersection of race, nativity, and place, specifically for Black pregnant people and their risk of preterm birth. So Ozzy was really interested in looking and diving into the granularity within Black people who are pregnant and what happened to their risk of preterm birth depending on where they were given birth in the country. And looking at that immigrant paradox, that immigrant idea that a foreign-born person might have a lower risk of an adverse outcome, does that look the same everywhere in the country? And what we found is that no, it doesn't, not for Black people. And so here in this graph, what you're seeing is the United States, and every dot is a county. So these were county level analyses. And the blue dots are where you see that foreign-born advantage. Remember the previous graph, the dark versus the light bar graphs, it seemed like the foreign-born individuals always had lower risk than the US-born individuals. But in our analyses, when we looked at across the country, not every county was showing that immigrant paradox for Black pregnant people. Some of them definitely were, especially where you saw bigger circles. But there's a lot of gray dots where there was no significant difference. Even after adjusting for lots of covariates, there was no difference between the immigrant and foreign-born Black person's risk of preterm birth in that county. And a few red counties that we thought potentially were data outliers. But it really starts to think about what is happening within a county that might be structurally advantaging or disadvantaging pregnant people, such that these larger epidemiologic trends that we see when we look at data across the country, we don't see these kinds of nuances and variation across the county. So maybe we really need to start taking those big national bar graphs within the context of a county and seeing, does this apply to our county? Does this apply to our hospital, our city, and what we're seeing in our patterns here? Which then begs the question, what is race and ethnicity and nativity representing? And what does it mean if it changes depending on where you live? So we go back to the basics. What is race? I know it's basic, and probably at this point you've heard a lot of talks about this, or I would hope, but let's just indulge me for a second. So what is race? A self-ascribed identity? Absolutely, yes. We can all say we potentially have a race that we identify with. Is it a societally assigned identity? Also, yes. And the best literature for this comes from our own field. If you look at electronic medical record race data, you will see that within an electronic medical record of one hospital, sometimes race is being assigned to patients without being asked of them, and it changes within a hospitalization, within a hospital encounter or a person's medical record. So we know that these concepts are being ascribed to people, and there's consequences to that. But at the end of the day, one of the things that we must understand is that it's socio-politically constructed, this concept of race. And nothing to me shows that better than if we look at racial categories in the US across the years. So you're not meant to read the boxes here, but what you're seeing here are all the categories that the US Census has used over time, starting from the very first census in 1790 through recent census. And this doesn't include the most recent one that came out. So take that with a grain of salt. But hopefully what you're appreciating is that every little box is a different color, is a different race. And those colors have shifted over time, and we've added colors and we've added boxes and we've added boxes because we are continuously changing our definition of race depending on the socio-political context and for economic reasons in our country. This is not how biology evolves. This is socio-political evolution, and that to me shows us how race should be conceptualized. So what does race serve as a proxy for? What does it represent? Well, it can represent many different things. And more, if you work in the field of racial disparities, reviewers and journals will be asking you to really name what it is that you are trying to use that race variable for. If you want to reference this paper in JAMA, it will tell you if you're submitting to JAMA and you're talking about racial disparities, you're going to have to talk in your methods and your discussion about why you collected that data and why you're disaggregating by that variable and what you think it means for your research question. So it might represent how an individual is treated by others. That's hard to capture in a big data set, so maybe we use race as a proxy for that. How a group has been treated by society, we get to the structure, exposure to health risks, disproportionate exposures to health risks, or potentially health promoting processes. The impact of cumulative transgenerational trauma, it can be a proxy for that. It can be a proxy for ancestral migration patterns if you take into account that continents have shifted. But what it does not represent, and I promise you to this day still shows up in papers because I review these papers, is that it are differences in genetics, differences in biologic susceptibility, behavior, or personality traits. And so part of what I hope you hear from me is even if you don't engage in racial disparity work or health equity work, when you see these concepts being used in this way, we are educated and empowered enough to say this is not an appropriate use of race and we need to reframe. Or reuse, rethink about how we're using this variable in our QI project, our research project, or whatever, however you're seeing it show up. So what is ethnicity? Ethnicity is a shared culture, language, ancestry, practices, beliefs. It's not interchangeable with race, but particularly for data purposes, and people might disagree, but I feel very strongly about this, is that it can and should be combined with race to create an intersectional identity. And that's really critical because for some reasons, for some people, they identify much more with their ethnicity than with their race. So when we disaggregate data and we only use race or we use ethnicity separate, we run the risk of really losing a lot of the important variation that might exist in your data set and your population because someone does not click a race, but will only click an ethnicity. So we really need to think about them as an intersectional identity that we need to always combine together. And that also comes up a lot. I see people do a race and an ethnicity and are not intersecting them in the way that would be more helpful. And then more salient to today, what is nativity? So nativity is where a person is born. You've heard me say that. And depending on how you're using the variable, you might define it like I do frequently as US versus foreign born, the easiest way to do it in big data. But you could also study it as country of origin. So where someone is actually physically from. And that really depends on the research question or the data that you're using for nativity. And this is obviously a US-centric study, right? If we were in Europe, it wouldn't be US or foreign-born, because there's a lot of immigrant health literature in Europe that depends on the country. But what does nativity then and immigrant status serve as a proxy for in data? We talked a little bit about race, we talked about ethnicity. To be able to really understand what nativity might represent in a research study or in a data set, depending on how you use it, we need to better understand immigration, right? And immigration immigrants as a community in this country, this again, a US-centric talk, to better understand what drives immigration so that we can understand when I use that foreign-born variable, what is it potentially representing? What is it serving as a proxy for, in the same way that we now better understand that race serves as a proxy for bigger, harder to capture things that we don't have in our data sets. I don't have in my birth certificate data sets. So what does it serve for? So let's dive into immigrants in the US. A little snapshot. So this is just data from Migration Policy Institute, which is a nonpartisan, basically think tank that puts out immigration epidemiology data for publicly available. And so what you're seeing here is across the x-axis is time. So you'll see 1840 actually, and then all the way to 2020. And on the right side, I believe, yes, is the number of immigrants, just number. But on the left, you're seeing the percentage based on the population, based on the US overall population. And so hopefully what you're starting to see is that the percentage of the US population, which is the orange line, it hasn't really changed that much since we started, because our population continues to grow. The number absolutely is increasing, but so is the general population. So that's kind of important to know, is that there's been dips and there's been valleys, and yes, there's been a rise recently, but it's kind of in line with our historical trends. Maybe that can help contextualize what we're hearing on the news. In terms of the demographics within the immigrant population, this is also data from the Migration Policy Institute. And so I just wanted to clarify what may or may not be being portrayed about what that immigrant subgroup what the subgroups within someone who identifies as an immigrant or who would be deemed an immigrant, what that looks like. So you have the majority of immigrants who are naturalized citizens, which is like me, born in a different country, but naturalized now, lawful permanent residents. Then you have temporary lawful permanent residents, and that blue is the unauthorized immigrants, which is less than a quarter of the overall immigrant population. And that does include people who are pending asylum claims and are DACA recipients, because we don't have a formal solution for them as of yet. Specifically looking at that undocumented or unauthorized immigrant population in the US, because this is the group when it comes to health research that is hardest to study. And so we have to really understand some of the trends in order to be able to even know how to study and how to develop policy around improving outcomes. But so this is some important data as well to give you knowledge and data different than what might be getting portrayed in the news. So what you're seeing here, it's hard to read, but basically it's over time, and we're looking at different subgroups in the population. And the dark blue is the control group, which is US-born individuals who do not have a high school education. The light blue is US-born individuals with a high school education. And then the red and the yellow are our immigrant subgroups. And again, undocumented or unauthorized immigrant subgroups. And you can see incarceration rates are really stable, do not really change over time, and are much different than the control US-born population. And then on the right side, what you're seeing is employment rates. So again, we see very stable employment rates. People are really trying to work, but very stable rates in terms of who is actually being employed relative to others. And this is something that has been studied in many different ways, but really we see, I think, a response these days to some of the trends that we saw between 1995 and 2010, where there's claims that unauthorized immigrants are really taking over a workforce. But when you take a bigger contextualized picture of the American workforce, you can see that this number has actually remained very steady. People are working as much as we can track them. Again, difficult population to study, but people are working, but at a relatively stable rate compared to the rest of the population. So when we think about that nativity variable and we think about what people are doing in this country, we also have to understand what brought them to our country to be able to understand then what does that nativity variable represent? How might that impact health-seeking behaviors or health outcomes? And really, if you want to understand migration in general, not just to the US, we have to understand that migration is driven by push factors and pull factors. People are either pushed from where they were born for a variety of reasons that I've listed there, or they're pulled to the receiving country, is the language, by, again, a variety of reasons that I've listed there. And understanding the differences between those push and pull factors, or how that might be driving someone's migration story, can help us then understand their risk factors for health-seeking behavior, for health access, or their risk factors for different types of health outcomes. If someone is being pulled for employment separation, for employment reasons, or for family separation, one family member is in one country and then the other, there is going to be differential risks to your health or differential behaviors than if someone is being pushed fleeing war and chaos. But if we lump all of those immigrants together, we're not going to understand that granularity and how that impacts health and healthcare. So to end this little portion, nativity may serve as a proxy for preferred language. That's a simple, blunt instrument for that. For instance, for me, I do not prefer Spanish as the language that I want to speak to my doctor in or that I want to discipline my children in. English is my preferred language, even though it was my second language. So it's an imperfect variable for that, but so is race for the things that we use it for. But we can think about it. Nativity may serve as a proxy for differential cultural practices around the individual, but also cultural practices at the level of a community. Disproportionate exposure to interpersonal discrimination and stress, again, that interpersonal individual level, but it can also serve as a proxy for some of those structural processes that we also think of when we think about structural racism. In this case, it would be structural xenophobia, structural barriers to health insurance, how someone is or isn't able to access by policy, structural barriers to health promoting social services in the same way, and we'll talk about public charge in a second, structural barriers to workplace protections, family leave, receipt of care, and preferred language. So this is what nativity may serve as a proxy for. When you add that layer on, you may be bringing in some of these processes into your data. So then thinking again about that first graph that I showed you, Alejandra's study, is how do we take our understanding of nativity and then start to try to say, like, why are these bar graphs looking the way that they are? Why do they look different by color? Why do they look different between the different races? And as with racial disparities, we really have to go back to the webs of causation or the causal pathways. And I love me a good conceptual framework, so I'm going to show you two. This is one that was developed actually, I think, by someone in the legal field, which is, they label it the web of causation. And what I've shown you here is an understanding of increased maternal infant mortality, and particularly racial disparities in infant mortality. And the circles right now that I'm letting you see are what we conceptually think about as social determinants of health, right? These education, income, housing, access to care. At an individual level, you start to see a little bit of neighborhood demographics or safety in an area. But this is really how someone is experiencing their life at an individual level, which is that social determinants of health. But this framework is critical because it then adds another level, which is the structure, how these different concepts like education, income, safety, and housing are being impacted by structural policies, regulations, laws that have been put into effect, and we are seeing them lead to disproportionate exposure to adverse social determinants of health for some communities over others. So really thinking about that structure that then leads to differential experiences of social determinants of health. The social determinants of health are not necessarily negative, right? We talk about them as if they're always a negative thing, but you can have adverse social determinants of health or positive social determinants of health. In this case, we're thinking about the adverse social determinants of health that increase risk of mortality. If we think about how this might apply to immigration status and policies, the status might live somewhere within the inner web, but immigration policies really live within that outer part of the web. And we have to think about them and study them similarly to how we now understand that we need to study redlining and its impact on healthcare access, on maternity care deserts, and ultimately on maternal and infant health outcomes. Immigration policies belong in that outer web. And if the web imagery isn't so great for you, you can also think of that like stream types of conceptual frameworks. This is similar concept, but just portrayed a different way. And again, preterm birth disparities at the very end, that's what I focus on. And we think about that preterm birth disparities, and Paula Braveman has been a leader in this field, but really what you're seeing here again is that those biologic mechanisms that we spent a lot of time really trying to study to change preterm birth rates and disparities are super downstream. And the social determinants of health that we mainly focus on as adverse are still downstream causes. They're mostly, they're mostly right here in the middle. Whereas the structural processes, like how we have economic disadvantage baked into our system, is the upstream cause that we need to really either study so that we can then explore how to change on a policy level. And similarly, immigration status and policy lives in those upstream to downstream causes. If it's an immigration policy at a federal level or a state level or even a county level, potentially that's the systemic structural xenophobic experience that then leads to the downstream health harming exposures of interpersonal discrimination that we might then measure down here. But truly, the best way to understand that immigration policies are social determinants of health is to look at some of the associative data that we have had come out in the last 30 years, because we have seen a rise of punitive immigration policies since about the 1970s, and specifically in the last 10 years. But punitive immigration policies are those that increase the threat of adverse legal consequence or deportation for someone who is foreign born. And like I said, they've been on the rise since the 1970s. There's a whole host of literature. If you're interested in this, I just highlighted a few that are interesting to me as a neonatologist who's interested in maternal infant health outcomes, but they have been associated with decreased use of public assistance programs, preventative healthcare visits, both for pregnant people and for people with young children, and then also increased rates of low birth weight and preterm birth. And some of the policies that have been linked to these outcomes are listed at the bottom, including the Arizona SB 1070, which now we have a new cousin of it that was passed in Texas. So I'm sure there will be research coming out around the Texas Show Me Your Papers law that was enacted this year. But also even the Muslim travel ban has literature around it, linking it to preterm birth. We also know that it's not just policies. Policies really reflect something else in addition to the actual law, right? Policies aren't passed in a vacuum. They reflect an electoral body, they reflect policymakers, they reflect potentially community values or practices that are impacting more than just someone in a state legislature. And so really interesting literature coming out of Texas about anti-immigrant rhetoric and media as adverse social determinants of health as well. And so this is a study that has its limitations, but I found just very interesting in terms of how out of sight of the box methodology it used. And so especially now as we think about how to use digital media and AI in our research. So in this paper, what they did, this was using Texas data. A healthcare system looked at their prenatal care use among US versus foreign-born pregnant people, but then they looked for Google Trends in their area, because apparently Google will give you data about what's trending in your particular area without much money. And so this is like publicly available data about what people are searching for in your area. And what they were able to do is find an inflection point at a certain point in 2015, 2016, I think it was, their inflection point, where there was, before that, not many people searching for things like build the wall, deport illegals, make America great again. And then afterwards, there was a huge rise in the number of times that people were searching those trends. So then they decided, they called that an inflection point, and they used fancy statistics called difference in difference methodology, which those of you who are interested in health services research and policy research should look into and can talk about. But using those, it's not simple before and after, it's statistically controlling for many different temporal and spatial trends. Using that inflection point as a before and after, and using the statistical methodology, they were able to show that people who were not born in the US were presenting for prenatal care later after that inflection point in Google Trends. And they were also having some downstream, there were some differences in some downstream outcomes, like their hemoglobin at the time of delivery. So are people presenting later and having something like anemia being diagnosed later? Very exploratory, just raises questions, but it shows you, A, that potentially there's something about just what's happening in the communication in your community and how that's impacting whether people seek care and how they seek care, but also that we can really leverage a lot of the technology out there to help us understand these processes that are really hard to study, right? That we don't have great data sets that exist. This is just more literature about the chilling effects of policy and rhetoric on healthcare use. And when I say the word chilling effect, I mean a decreased utilization of either health or social services as a result of fear or misinformation or confusion because of a policy or something that happened in the news. And so we've seen lots of literature now. This is just a few examples of the chilling effects of the 2016 presidential election with all of the rhetoric that it was known for on access to prenatal care among Latina pregnant people, increased preterm births among Latina pregnant people, and decreased primary care utilization, particularly among adults in a population that were deemed to be most likely undocumented. But the policy that I've been very fascinated with and that I've been really trying to be actively mitigating the impact of is the public charge rule change. And so if you learn about immigration policy, then you must understand the public charge rule. This was a rule that had been in place in our country for many, many years, decades, hundreds. And it really defined how an immigrant could be labeled a public charge by the government, such that they would then either be, if undocumented, be on a pathway to deportation, but more importantly, if they were not undocumented, might be declined a pathway to legal residence. So how the government decided, you as an immigrant, you're a public charge, and therefore we are not going to give you a pathway to residence and actually deport you. And it used to be a limited definition of how you could be labeled a public charge. Here is how it was defined before. If you were requiring supplemental security income to survive, if you needed temporary assistance, or if you needed institutionalized long-term care, then you could be deemed a public charge and be at risk of what I mentioned. In 2018, the administration leaked proposed changes to this public charge rule, deciding offering that it was going to expand how someone could be labeled a public charge in our country. And it was much more expansive, and for the first time really included a lot of either straight health insurance or health promoting social service benefits. And it was just a proposed change, but it got a lot of media attention. And even before it was fully enacted in 2019, everyone knew about it. If you were an immigrant or you worked in immigrant communities, people knew about these changes. And we started to see the impact of it. And so you can see Medicaid was included in that list, which if you take care of children, as I know we all do, that's a big deal. More importantly, what happened is that it became this idea that if you used any government or social benefit, you could be deemed a public charge, or anyone in your house could be deemed a public charge. So if a child used Medicaid, their parents could potentially be deemed a public charge and be at risk of deportation. So it led to a wildfire of fear and wildfire of misinformation and confusion. And so it should be of no surprise that we are now seeing lots of data around the chilling effects of the public charge rule. Decrease, and you'll see that SNAP was not necessarily on that list, and WIC was not necessarily on that list, but we saw decreased utilization of programs like, and I didn't even put the WIC data in here, some of that is newer, but SNAP, National School Lunch Participation amongst the children, decreased prenatal Medicaid enrollment among immigrant pregnant people, and decreased SNAP use and Medicaid use during COVID-19 as well. So we understand that these policies that are happening on a big scale that you and I may not be able to change are having an impact on how our patients and their families present to care, the decisions that they're making, and certainly the impact on the children that we care for. So how do we contribute? This feels too big, right? But what I want to focus my career on, what I've started to focus my career on, is not just documenting the disparities that we all know are there and maybe understanding them a little bit more granularly, but what if instead of just focusing on the structural discrimination and the structural xenophobia, we could build structural resilience. This concept of resilience, which has appropriately gotten a lot of bad press of late, how about we reinvent it and think about it less on an individual level, much like a risk factor, but think about structural resilience in the same way that a policy could be a structural risk factor. And so really thinking about resilience as societal, community, and family, not just the individual physiology and cellular. And this framework comes from the nursing literature, but it really helped me open my eyes to thinking about resilience as a potential structural factor. So dive into nursing literature, it might teach you a lot. So this is my career, structural resilience for immigrant diets. How do we think about where they're from, their migration journeys, their relationship to our healthcare systems, their communities, and really optimize outcomes for the dyad? So I think a lot about how we mitigate the chilling effect that I showed you data on. How do we study legislative policies that might mitigate the badness? But how do we have some healthcare-led strategies as well? Because I think both of these are important contributions to how we optimize immigrant health outcomes, potentially in a sociopolitical climate that is determined to not optimize immigrant health outcomes. And there's certainly work that we can do as people who are educated and people who can read a paper and understand its implications around advocacy for legislative policies, and that's certainly part of what I do. But there's something that all of us can do within healthcare-led strategies. So from the legislative policy, as a researcher, I became really interested in sanctuary policies. It's a tough thing to study, but sanctuary policies are protective immigration policies that at the heart of the definition is about limiting partnership between local law enforcement and federal customs and immigration, ICE. And so it's these ideas that if you pass a sanctuary policy, and they can be enacted at the state, the county, cities, even hospitals have enacted them, that you will do your job and you are not going to do ICE's job for them. And if you live in, well, if you're aware of some of the the trends that are happening in some really punitive areas, sometimes there's a lot of collaboration between local law enforcement and ICE, such that people are being held for the purposes of ICE without committing crimes. And so a sanctuary policy is meant to limit that partnership, and like I said, can be enacted at various levels. But what's interesting to me, because hopefully you've understood by now, that I see a concept or a variable and I think about what it might represent on a bigger level. So to me, sanctuary policies might represent or be a proxy for something else about that neighborhood that I can't really measure, particularly on a large scale and an administrative data set in a big country. But something about like the policy orientation of stakeholders in that area, or policymakers, neighborhood attitude, something that may be reflective of something that's health promoting that I can't really get at otherwise. If an area enacts a sanctuary policy, is there something about that area that maybe also be promoting health among immigrants in other ways that are hard to get at? That's a theory, but the first thing we had to do to really be able to study sanctuary policies is to map them and understand them across the country. So with one of my mentees, now friends and colleagues, Dr. Robin Ortiz, who's at NYU, we did a content analysis of US sanctuary immigration policies and how they might be studied in social determinant of health literature. And it started with mapping. We can't study and change what we don't understand. That's always what I tell people, tell my students. But so this was us looking at sanctuary policies enacted in the US by year and year jurisdiction. So whether it occurred at the state level or the county level, what years they were enacted, were they enacted as a result of certain local areas, and then also the language, because what we found is that the language of these policies change so dramatically by year and sometimes by location, with some being very focused on that limiting that partnership, and others being very much worded about protecting and uplifting and welcoming immigrant communities. And there certainly seem to be differences in terms of where those types of policies live compared to the ones focused on law enforcement. But we created a data set to be able to then be able to think about sanctuary policies as a variable in a bigger model. And then separately, after we did that work, we've collaborated with several people. I'm just showing you one example, but Robin and I have collaborated with Dr. Aditi Vasan, who's a general pediatrician at CHOP, a hospitalist pediatrician at CHOP, actually, who was really interested in how sanctuary policies might mitigate the chilling effects on child insurance coverage that we saw related to that public charge rule. So can you use this variable and see that there's a difference by where someone lives? If there's a sanctuary policy, does that chilling effect seem to differ based on whether or not the population had a sanctuary policy in place at the state level? So thinking about that sanctuary policy kind of as the mediator, mitigator of the known negative chilling effect of this adverse punitive immigration policy. And we've done other collaborations. And so that's another lesson for people who are in the room. There's so much joy in collaborating if you do research. To do this study, we used data from the annual social and economic supplement to the current population survey, and you can see the years that we used here. And then we did a sub-analysis focusing on just pre-COVID times. But what you're seeing is our population and how we broke this study cohort down. Every child in our cohort was income eligible for Medicaid. And then we looked at citizen children, who by definition are eligible because they are born in this country. They are eligible for Medicaid. If they're income eligible and born in this country, there is no stipulation. There should be no barrier. And then we looked at non-citizen children, but we were also interested in mixed status children. So children who are living in families where someone might have a different status than them, because there's a lot of literature about how even mixed status for a citizen child can affect their healthcare access and their health outcomes. So you'll see that breakdown for the citizen children, where you have children with non-citizen parents. Those are the mixed status children, and in our control group, where there may be an immigrant, but it's more than 2 generations away. This was the question in the survey that we used. Was the child covered by Medicaid? We had a pre-intervention, a post-intervention, sanctuary states, and then control states were states that did not have a state sanctuary policy. We again use a difference in difference causal inference technique for this study. And I'll just skip to the findings that we are about to get published here. And what we found is that after the 2008 public charge rule change, low-income non-citizen children, so foreign-born children, had a 9.3% greater probability of Medicaid participation if they lived in a sanctuary state versus a non-sanctuary state. So for those foreign-born children who may be eligible, probably are eligible depending on their own status, If they lived in a sanctuary state, a very, very blunt variable, right? This is a variable at the level of a state. If they lived in a sanctuary state, there was a statistical difference about whether or not they were enrolled in Medicaid during this, in this post period after the public charge rule change happened. So something is being measured, and I still don't fully understand what that state sanctuary policy measures. That's absolutely a limitation, and I think personally that we'll need a lot of mixed method work to better understand what these large state level variables mean in people's lives, but a signal we should explore because potentially it's a form of resilience at the level of a policy, and that may be able to have an impact among our own communities. So we'll end with what we can do about what we can think about during our own healthcare systems. And I'll highlight one study of mine that I love to have that conversation. This is the PRIMA study, the Promoting Resilience in Immigrant Mamas study that we did in Philadelphia, where we interviewed pregnant or recently pregnant Latina birth parents about how their pregnancy went, tell us their pregnancy stories. They had to have been pregnant in the years after the public charge rule change. Tell us what their use of prenatal care was, and in particular, what their use of nutrition and WIC benefits. And this was a specific add-on to the study because I had heard a talk by a local council member in 2019, early 2019, where she had come to CHOP Policy Lab, which is one of my homes at CHOP, and told us that the city had to close a WIC office in North Philadelphia, which is a huge Latino immigrant enclave community. And she didn't know why. She didn't know why people who were coming to this WIC office had stopped coming and they'd had to close it for lack of utilization. And why was this happening? Why was this starting in 2018? And those of us in the room who are immigrant health researchers were like, we know why, but we have to document that and we have to understand that locally. But that's why we asked about WIC specifically, because in Philadelphia, it was an issue. And we are a sanctuary city, by the way. And so the hope was that with the stories that we gathered, we could potentially have people translate their experiences and their opinions into potentially actionable strategies and policies that we could all locally implement. We applied the principles of community engaged research, reproductive justice, and birth equity, which are incredible frameworks that I've learned so much from, and they originate from the Black maternal and infant health racial equity literature, and not even scientific literature from the advocacy world, to really understand how to design this study. Because if you think about it, we are asking pregnant or recently pregnant immigrant birthing people at a time when it's scary to admit any of those things, what they did during their pregnancy and how they feel about immigration status, and how we didn't ask them their immigration status, but every single one of them eventually told us in their own way, and how they were seeking care and what they were scared of. And so it was so critical that we designed the team to be able to have those conversations and ask those questions in a way that minimized power dynamics, power imbalances, and was really attuned to how we recruited and who we were able to have in our data set. So it's a very diverse research team. We recruited very intentionally to make sure we had bilingual Latina interviewers who were ethnically and language concordant. And then we did thematic analyses and also offered correct information to all of our participants so that we were correcting misinformation just through the course of our study. So I'll end with the key findings of this study, one part of it. So what you'll see here is that as a qualitative analysis, we had themes within our interviews and there was sub-themes within those interviews. And so I'll talk about those. And that's the data from our participants. It's what our participants told us. But then we took it one step further and translated some of those themes into potential interventions that someone, a healthcare system, a clinic, or a healthcare provider might consider based on the sub-theme that came from our data. So for instance, the first sub-theme should surprise no one, especially here, that to improve prenatal care delivery, we really need to increase the ability to communicate in preferred language in every part of a clinical encounter. Obviously, right? This is not rocket science. And families also wanted to really understand the financial costs. There was a lot of stress and anxiety about what it would cost to have a baby and how they would ever recover. There was so much misinformation around that. But what was really interesting about the preferred language is that the stories weren't about not communicating with their provider. The stories were about not communicating with the rest of the healthcare system outside of that interaction, with their one-on-one interaction with their nurse practitioner or their doctor or whoever was providing their prenatal care. The struggle was in calling to make the appointments. The struggle was in communicating with the MA, was in feeling Discrimination during those parts of the encounter was in just not going back to a clinic and then waiting a few weeks to months because that was so stressful. So I'm going to try to find another clinic that maybe when they answer the phone, there's an option for me to talk in Spanish, but prenatal care was delayed. And so really thinking about how we translate that into interventions, we have appropriately done so and focused so much on how we use interpreters at the bedside when we hold family meetings and during rounds. And I'm not saying we should stop that at all, right? But we also have to think about how we use and create systems to be able to use interpretation services in every other part of the healthcare encounter that may be gatekeeping families from our care. So how are we training front desk staff and people who answer phones about using language lines? Have we created a separate language line where you can call and be connected to an interpreter before you're connected to the receptionist? That's something that we've developed at CHOP through language services. We also need to really formally test people's actual language abilities, because there is definitely data around how we might overestimate our ability to actually communicate. And so are we not just hiring bilingual staff, but formally testing interpretation ability? And then the last one I mentioned, the telephone encounters, is really critical and something that every healthcare system should think about. For increased education, for us, that is really something that comes down to our community partnerships and how we can really, we may not be the right venue or voice to be able to teach to someone, but we can absolutely partner with community groups who are trusted to combat misinformation. And the last two that I thought were just so interesting is that people really wanted concrete reassurance that they were not going to be reported to ICE. And this seems obvious, right? Like, of course I wouldn't call. I'm just taking care of you. But we saw differences in the interviews between people whose providers specifically said that to them and those who wondered about it for their entire length of being pregnant and giving birth. It's like, is someone going to call ICE? It's just something I worry about. Versus the families who were like, my provider, doctor, we had a lot of nurse practitioner families taken care of by nurse practitioners who were like, I was looked in the eye and I was told, it doesn't matter. I'm not calling. We're here for your care. And there was a difference in the experience that led through the pregnancy. That's hard to operationalize if we think about that, right? And I can't just say that and say, so make people feel comfortable, right? Because I think there can be a lot of harm to these conversations if not done in the right way. We can create more stress, we can create more fear if we aren't having these conversations in the right way. So how do we operationalize that? Perhaps we think about ways that don't necessarily put the onus and focus on an immigrant receiving that information through signs or handouts. Potentially, we think about how we train healthcare providers to have these conversations, much in the same way that we do a lot of training around breaking difficult news, relaying medical errors. This is not simple conversation. So there is absolutely so much room for our med ed colleagues to really help us in how we train ourselves and our new generation of healthcare providers, doctors, nurses, about how to have these conversations about immigration status, but that will require us to understand the policies in our area. So a lot of med ed driven work that can arise from some of these studies. So in conclusion, I hope that you understand or have heard me say that drivers of health disparities exist and must be addressed at both individual and structural levels. This absolutely applies to immigrant perinatal outcomes. We've studied resilience so much at the individual level, and I am just as guilty of that, but we can also study it from a structural perspective. And there's many ways to do that, to build structural resilience for any minoritized family. My focus is on immigrant families, and we can use research, that's my bias, but we can also use QI and med ed, and we really need to use all of those strategies. And lastly, there is absolutely no way to do equity work without uplifting our voices within our democracy. So I wanted to remind everyone that voter registration efforts are critical equity and advocacy work, also by registering ourselves. You must register by October 21st, but also by helping our families register, right? We are able to be with families sometimes at the worst part of their lives. At least I, in the NICU, am in that position. And those of you who are in primary care may not necessarily be in that position, but we are interacting with families. We have a sacred ability to remind families that we also want their voices in our democracy. And so Vote ER is a great resource for people who are trying to promote voter registration within healthcare spaces. We are having a week-long voter registration efforts at CHOP this week. Our NICU specific voter registration drive is on Thursday because I'm here today. But this is advocacy work and this is equity work. Without voting, we cannot change the policies that absolutely impact health in our communities. And with that, I'll end and see if there's questions.
We have some time for questions. Dr. Mendoza, please come to the mic.
Excuse me, this was an excellent presentation because I think it gives us insights about how much we don't know and what we need to think about. As you know, 1 in every 4th child in this country lives in an immigrant family.
That's right.
By 2060, that would be 1 in every 3. California has 46% of our kids that live in an immigrant family. Santa Clara County, where we are right now, has 40% of its population not born in the US. So at the end of the day, this is everyday practice.
Everyday
And
pediatrics.
how we approach this is really important, and not just for the quality of care, but for the efficiency of care. I think when we look at healthcare now and in the future, we're going to have to look at quality and efficiency. And I think it's not just about language, but understanding the aspects of who people are. And it's not just about immigrants, about everybody. So I really want to compliment you on the work you've done. It's been really a national effort, and you're one of those leaders that will make a really important change for pediatrics for us. Thank you.
Oh, thank you. Means a lot from Fernando. I met Fernando when I was a medical student, so it's exciting to hear that.
Any other questions from the audience? Okay, I have a question for you, Diana. I think it's amazing, and there's so many of us, especially here at Stanford, who are working kind of at the national level and in advocacy. And then you talked a little bit more about more local health systems. And then you mentioned a few things that we could do within our hospital system. And I am also one of those people who feel like there are gatekeepers to access to care, even at our prestigious institution, in terms of families who can't speak English and can't access the information about their child. But what on a daily basis do you do? I'm a neonatologist like you, so I'm just curious to hear what you do on a daily basis to kind of instill structural resilience for our patients.
I think that's a great question, and my answer continues to evolve. And so that's the first part, is that I don't think we need to have all the answers at the same time, at all the time. So we can continue to evolve and think of ways to change our systems. But one of the things that I think is really important is that, particularly for minoritized communities, is the hidden aspect of the experience of a minoritized person who is experiencing discrimination, and whether that's at an interpersonal level or a structural level. And so one of the most important things that any of us can do is see people, see families, and make them feel seen. And that can happen at the bedside during rounds, but it certainly can happen even a little bit structurally, depending on what we say during division meetings or case conferences and what perspectives we raise. That's advocacy, right? Like when we are discussing a case and we bring up a different perspective, we are helping families who don't necessarily have a voice or have reasons to want to stay hidden, have a voice in a way that can really start to change a culture. So what you say at a case conference about a random outcome that, right? Like if you have your, in neonatology, we worry a lot about central line associated bloodstream infections and what we can do to decrease them. There's literature out there that families who prefer language other than English have increased CLABSI rates. That's really like troublesome, and like, why would that be? And so even raising that question about why do we think that is at a case conference might be able to start to have our families be seen in a way that otherwise they would not be seen if someone wasn't advocating for them by just raising the question. And so I think that's something we can do no matter what role we have within research or otherwise. Friend?
Great talk. Thanks for sharing that stuff. It appears that there may be a discrepancy that I can't rationalize between the data you showed about American-born immigrant populations and non-American-born immigrant or minority populations, where it appears to be protective to have not been born in the US. And yet it seems like the journey of an immigrant coming to the US, in many cases, a challenging one. You showed a lot of changes in how we provide services, or maybe what people perceive to be available. So why is it then that it still looks like you're better off coming here and having a baby than being born here if you're a minority and then having a child after being a citizen?
I love that you are highlighting the immigrant paradox, which I didn't spend a lot of time on because I was hoping to get to policy. But the immigrant paradox is this notion that if you have a racial, ethnic, minoritized group, that they are going to have a better outcome than if they were foreign born than their US born counterpart at the level of a population. So the dark light colored bar graphs, the immigrant paradox. And why might that be when they are similarly minoritized by race or ethnicity, but they have the additional barriers of language or the migration journey? And so that notion of the immigrant paradox has fascinated epidemiologists, and it was literally every theory that could be employed to try to explain it has been explored in terms of, is there something different about immigrants? Is there something different about their health in their sending countries? Is there something different about the healthcare system in their country? Are they, the other theories I've explored, like maybe people are leaving the US to have their poor outcomes and they're having their poor outcomes. We've debunked that. But the idea had always been like, for some reason, that's always the case. And I think what we're better understanding is that that's the case in cross-sectional data, particularly when you look at more recently arrived immigrants, if you're able to have that level of granularity. But when you have immigrant, and you think of immigrant communities as families and generations, that paradox, it goes away. So the longer that you spend in this country, that paradox seems to erode. If you are arrived as a child and grew up and have your health outcomes in a population being measured when you're an adult, you start to look no different than someone who was born here compared to someone who might have more recently arrived, particularly for chronic illnesses. And so really, I think some of the understanding is coming to this idea that it's not necessarily the migration journey that's creating that immigrant paradox, but rather the paradox is not relaying what happens after being here for long periods of time and having children and being exposed to our environment as a minoritized person. And so is it about the environment that an immigrant family and community is really living in and the journey that's happening that could be explaining why, if you live in a recently arrived enclave and you have a structural resilience around enclaves that we haven't fully understood, but that there's research around, then you're epidemiologically going to look like you have better outcomes. But over time, that foreign-born community, again, I say specifically community because I think it's hard to think of the individual, but that foreign-born community, especially over time and generations, that paradox goes away. And so thinking about the paradox not as this black, white, if you're foreign-born, you're absolutely going to have a better outcome, but if you're foreign-born, what are you actually, in a data set, are you measuring recent arrival? Are you measuring time in country? Because the outcomes vary depending on those things. So it's not that black and white. And I definitely came to this research thinking like, we just have to find what makes immigrants have better health outcomes and what is that resilience point? And sadly understanding that that resilience goes away and it erodes. And is eroding kind of faster in some places compared to others. We're definitely seeing decreased immigrant paradoxical better birth outcomes in data that's coming out of the last few years among Latina birth outcomes. And so wondering like, what is it that makes a paradox erode? So what were we measuring in the first place? A convoluted answer to say that I don't think the immigrant paradox bar graphs really tell the story of immigrant health in the US. Sorry, yes, long answer. Thank you.
All right. Well, I think we've come to the end of our hour. Thank you so much, everyone who joined us online. And thanks for those of you who came in person this morning. Have a good day.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.